So my topic here is premix insulin in type 2 diabetes in insulin naive patients. So while initiating the discussion, I will just tell you that currently is an era of health check packages. We have every patient coming with a bunch of reports, and when you skim through it, you see that fasting sugar is there but post-food sugar is never there. And the simple reason is that healthcare package does not afford that for the cost efficiency, because it involves one more visit and one more test. So that test is always bypassed, and patient does not ever understand the importance of post-meal sugar, and ultimately ends up in complications. So here, importance of post-meal sugar has to be reiterated to the patient and the laboratory also, if possible. So first of all, we must understand that insulin is required for every diabetic at some point in life. Very few are exceptions. Very few escape the insulin, but most of diabetics need insulin, and that is the time we should understand the reason for initiation of insulin is mostly glucotoxicity. A newly detected diabetes comes with 400-500 sugar. His pancreas has gone numb, and we need to have injection in place, and that is the time when we can tell patients that this is a temporary insulin. We can control the sugar and then taper it off. Wherever other conditions are there where rapid control of sugar is required, pre-operative fitness, or where SMBG scenarios have shown very high sugar, we need to bring it down. Early effective control lowers the microvascular risk. We have to reiterate this to the patient. So when we have seen the things, we have mostly heard that basal insulin is very simple to start, easy to remain with. But most important thing is that it takes care of only fasting sugar but leaves postprandial peaks unattended. And in high carb eating society like ours, we have PPG derived A1C more often seen, and hence PPG excursions are linked to endothelial dysfunction and CV risk. This has to be treated first. So basal insulin leads to slower reduction of A1C when PPG is contributing more. This leads to treatment inertia and false sense of security and more complications. Indian reality, we know that we are high carb eating society and with big PPG peak, and where PPG is always ignored. Even patients who are coming from SMBG, they bring only fasting sugar, if at all they bring. And that is very frustrating when we see the sugar chart. ICMR NIN dietary data shows that cereals contribute 51% in urban population to 65% in rural population as daily energy source. Protective foods like pulses, dairy, vegetables, fruits are often not in enough amount that is required. So addressing meals and educating patients about their carb eating is very pragmatic while initiating insulin. When we talk of comparison between basal and premix insulin, we must know their action potential. So slow onset of basal insulin is a good thing for avoiding hypoglycemia, but when it comes to sugar control, it has got a flat or no peak profile, and hence it does not control the post-meal sugar as much as it controls fasting sugar. As compared to that, premix or co-formulations, they have dual action. One rapid component to take care of the meal, and the another one long-acting component gives basal coverage. It starts producing effect in 10 to 20 minutes, peaks in 1 to 3 hours. Intermediate tail covers the intermeal and fasting sugar. So dosed with major meals in BID or TID when required, it targets PPG very early and achieves HbA1c reduction very early in the course of treatment. What is the evidence to support the premix usage in postprandial control? Initiate the RCT which compared biased 70-30 compared to glargine once a day. In insulin naive patients on OADs, it was a trial which was conducted for 28 weeks and algorithmic titration was applied. So at the end of 28 weeks, premix produced HbA1c of 6.91 compared to 7.41 of basal. So there was a 0.43 difference in HbA1c. So HbA1c was achieved by more number of people compared to basal, and there was a higher incidence of minor hypoglycemia and weight gain in premix users. So whenever there is HbA1c more contributed by prandial sugar, starting premix or co-formulation is a very pragmatic solution. Another trial, 40, treat to target in type 2 diabetes trial, premix versus prandial versus basal was compared. 708 patients were randomized who were on metformin and sulfonylurea. They were given either premix BID, prandial TID or basal detamir. So 1 year data was very encouraging for premix. So A1C was 7.3 for premix, 7.2 for prandial and 7.6 for basal. So hypoglycemia and weight, again if ignored, then A1C was better controlled with premix and prandial. Further to that, in 3 years, after intensification as needed, proportion at 6.5 was lower with biphasic compared to basal and prandial. So as you go on with the duration of treatment, the picture may look different, but ultimately the game is about titration and adjustment of the dose. So if you educate the patient, you can get good result with premix in fasting and postprandial sugar both. So further to this evidence, several RCTs initiation with premix can reduce A1C more than basal only when PPG is dominant. So hence the checkup of PPG sugar is very important. Meta-analysis show overall similar A1C with premix versus multi-dose regimens. Differing profile of FPG and hypoglycemia is of course to be considered. Clinical choice should reflect dietary pattern of the patient, cultural pattern of the patient, baseline A1C, hypoglycemia risk, patient's preference and choices, and capacity and affordability. So all these factors guide us in choosing the insulin. So who will benefit from premix while starting in insulin naive patients? So people who have got high baseline A1C more than 8.5 with marked PPG excursion are likely to benefit most. Who have predictable lifestyle, predictable mealtime and predictable diet, they are the fit people for receiving premix because they have predictability in their all the aspects. High carb dietary pattern typically in India encourages us to use premix more compared to basal. This is a condition, like this is a slide for people who have never used bias, but I think our crowd is always using premix, so this we can bypass. This is the comparison between premix and basal on multiple virtues. HbA1c, for example, is better controlled with premix compared to basal. PPG control, of course, is better with premix. Fasting control as a primary effect is better with basal insulin compared to premix. Hypoglycemia is higher in premix group compared to basal. Weight gain is higher in premix group compared to basal. Number of injections, premix has 2. Basal is 1, but with time basal is always insufficient and we need to have boluses added to that. That ultimately becomes more number of pricks, which is less preferred by the patient. Basal insulin gives flexibility to the patient compared to premix. Again, this is a slide reflecting initiate and 40 trial where it was shown that people like HbA1c was better reduced with premix compared to basal. These are the essential guidance points to the patient. Educate on hypoglycemia, recognition, management, review SMBG and CGM patterns and guide them. Meal regularity is very important while prescribing premix. You should ask them to be predictable as far as calorie contents are concerned. Increase more lower GI food and fiber. Injection technique has to be inspected for all, but more so with premix, site rotation has to be advised. Take home message is that high PPG excursion patients need premix right from the outset. That leads to better HbA1c and less complications in future. Thank you very much.